Yes, so my name is Jeroen van Dorp, and I work as an MD PhD student in the group of Michiel van der Heijden at the NKI in Amsterdam. So the prognosis for stage 3 urothelial cancer is quite poor, and this can be modestly improved by treating patients with cisplatin-based neoadjuvant chemotherapy. However, for a large number of patients, this is not an eligible therapy, and therefore we decided to treat patients with ipilimumab together with nivolumab in the first cohort of NABUCCO. So these results were published already, where we saw a 46% pathological complete response rate. And now we have a second cohort in which we are treating patients. And what we observed in our first cohort was two things, actually. So the exposure to nivolumab was quite low due to how the schedule works. So we also added nivolumab to the first cycle next to ipilimumab. And then in addition, we have seen in melanoma that EP1 should be as efficient and has shown better tolerability versus EP3. So we had for the second cohort, which you have now presented at ESMO, we have two arms. So in one, we are treating patients with EP3 and Nivo1 for 2 cycles, followed by 1 cycle of nivolumab. And then and the other arm is with EP1 with Nivo3 for 2 cycles, also followed with nivolumab. So that's our study design, and we're treating the exact same patient group as in our first cohort. So that's stage 3 urothelial cancer, and CT2 is excluded. Yes, so in the metastatic setting, it seems to be that carboplatin is a bit inferior as opposed to cisplatin, and in the neoadjuvant setting, yeah, it's also a bit controversial whether carboplatin is a good alternative. So we do treat patients with carboplatin, but we often give them the choice then to either take carboplatin if they're eligible for that, or to participate in a study. So for instance, for our NABUCCO study, a lot of patients are actually referred to our hospital specifically for the study or are interested to participate in a trial with immune checkpoint inhibition. So in that sense, it was relatively easy to recruit the patients. Yeah. Yeah, so if we look, for instance, at the CheckMate 32 trial, there are patients in the metastatic setting have been treated with nivolumab alone, and also the combination with high EP together with nivolumab. And also there we see that this just yields an overall better response rate. So probably it's the case in bladder cancer that nivo alone has some efficacy on the tumor, but the addition of ipilimumab especially really contributes to a very good survival and a good response rate. Yeah, there's probably a biological mechanism behind this. This could probably be an additive or synergistic effect between the two agents. If we look at, of course, Abacus and Pure1, we know that they're only using monotherapy. And so this is probably just solving part of the puzzle, so to say, and really the addition of ipilimumab probably really increases that efficacy. Yes, so there are multiple things that we would like to investigate or are currently starting to investigate. One of the things would be that, of course, we see a high number of patients that say a pathological complete response after surgery. And perhaps for these patients, it would even be a good alternative to treat them with a bladder sparing treatment. So that is something that would be interesting to investigate. Also next to that, of course, it would be interesting to see if we can compare this to standard therapy. So first, that would be in the cisplatin ineligible group of patients. And there it would be either be compared to, I think, carboplatin maybe, or investigator's choice of another alternative, maybe direct radical cystectomy instead. Yeah, and after that, we could also maybe think of comparing this to cisplatin in the cisplatin eligible group, of course. So that would be I think, a good control arm, as that is the standard of care for the neoadjuvant patients here with this stage disease.